So we prepared 2 cases, and we would like to be as interactive as possible. So I will present the first case first. So it's a 67-year-old lady. She has a negative medical history, except for a mild hypertension. And she had a prior surgery, cesarean section, which was the only abdominal surgery. And the familial history is negative, except for 2 nieces out of 20 with breast cancer. She had regular pap smears and mammography, followed by her GP. So a classical case. Then it starts. She had pain in the right fossa for 3 months, no gastrointestinal or urinary complaints. And 2 months ago, the GP ordered a colonoscopy, which was normal. So I think this is also a classical for what we will see in a minute. Then the pain continues to increase, and the GP asked for a sonography of the abdomen, which was normal. But he did the CA125. I don't know why. Which showed an increase to 125. So it's a real case. The CA was normal, and then the patient was referred to the ultrasonographic department where there was a vaginal ultrasound performed. Now I have to take care, but I think I checked that with Dirk, so I think it's correct. The left ovary is composed of solid areas and is fixed between the uterus and the sigmoid, and the color score was 2. The right ovary and the upper abdomen were, as far as seen on ultrasound, normal. This I have checked with Vincent van der Kerveye. On the left panel, you see the diffusion MRI showing a pathological uptake in the left ovary. I think that's clear. And infiltration of the sigmoid. That's the ovary, and that's the sigmoid. I won't show all the pictures because I think Vincent has shown enough, but I will show one more. On the left side, you see in both paracolic gutters tumor there, and also again the infiltration with the dashed arrows. The further findings on MR was peritoneal carcinomatosis in the pouch of Douglas, and small metastasis in the omentum, small nodules on the right diaphragm, no pathological lymph nodes, no tumor in the thorax. So the question and discussion which I would like to have is, what should we do with this case? Of course, many of you are imaging people, but I would like first to ask Christina for comment.
So we have a good, a patient with a good performance status, relatively young, no comorbidities. The tumor dissemination pattern as described is completely operable. We don't have massive ascites, no pleural effusion, no extra-abdominal disease, which shows distant mets. I would go for primary debulking.
Somebody else? What would they do? Unfortunately, I can't ask what they would do in Prague. Of course, they would have seen all these metastases on the ultrasound again.
Exactly.
But in Rome, Antonia, you're also checking with ultrasound, and what would the gynecologic oncologist do?
Giovanni would also do primary debulking.
I mean, in our institution, perhaps first the laparoscopy, and then primary debulking surgery.
Yeah. So laparoscopy is also what we did in the past, and in this case also we did a laparoscopy first, which confirmed the findings of the MR, of course. Any other comments? Milano? They left? No? Milano, primary debulking? Bologna?
I was not convinced of the ultrasound image, but we We usually do a diagnostic laparoscopy in the case there's any minimal doubt on the resectability.
Yeah.
Otherwise, we proceed to primary debarking surgery.
Yeah.
But I wasn't convinced about the ultrasound image. Wasn't really that clear of
What
mass.
didn't you like in the ultrasound? What didn't you like in the ultrasound? What didn't convince you?
There was no clearly defined mass with highly suspicious for malignancy. So
But
No,
if you
it
have
was not.
It's
No, it
just
was
an
not.
image, of
It was
course.
not. It was not highly suspicious.
No,
I agree.
true.
I agree. The MRI was suspicious because of the
That's
restriction.
why in my institution, perhaps this patient, perhaps she doesn't go whole body magnetic resonance because we don't use it routinely. So perhaps, but we cannot comment because perhaps the ultrasound examination was a little bit different with more informative than the picture you showed us.
Yes, of course.
Yeah.
Of course. I agree.
But if you see in the MRI peritoneal implants,
It's a matter of experience. It's a matter of experience. Maybe, I mean, if you have a very skilled sonologist and not that expert radiologist in the gynecological field, you may rely more on the gynecological scan and opposite in a different location. So it depends on, of course, as we have said, where you work, where the setting.
Yeah. Any other comments? So I think we agreed. So this patient underwent a primary debulking with extraperitoneal hysterectomy, BSO, en-bloc resection of the rectosigmoid, with anastomosis and pelvic and aortic lymphadenectomy, omatectomy, peritoneal stripping, and diaphragmatic resection to R0. And it was a high-grade serous ovarian cancer, but no apparent familial history. So the next question is, it's not in this case, but it could have been possible. What would you do when you see this? This is a clear node, both on PET-CT and on diffusion MRI. Let's start with Christina.
we had this discussion when we discussed the case. I would still go for primary surgery. It's if you compare the bulk of disease in the abdomen, which is massive disease compared to this little nodule extra-abdominally, and the rectal tumor, would go for primary debulking so that the patient can take also Avastin in a stage 4 disease, which I would be a very coward to give with a sigmoid involvement, which I wouldn't have had resected in the beginning because I would be afraid of fistulation. So I would clear the pelvis, I would clear the abdomen, which is pretty straightforward in this case. It's not massive disease in the abdomen. And then give from the beginning Avastin and carbotaxol.
Vincent, maybe you can comment. How convinced are you that this node is positive? 99%. Yeah. We've done a lot of ultrasound-guided endobronchial biopsies of this type of nodes, and with this picture, I think it's 99% it's positive. I think in this case we even confirmed it.
So this is not only by imaging follow-up. Most of the nodes we had were actually confirmed by pathology. Of course, it's a problem for the parasternal nodes. You cannot reach it with biopsy, but we had many nodes in the axilla, so the supraclavicular regions or other regions where there was biopsy confirmation.
Only the carina.
And correlation with the PET-CT, after all. There's little chance, except after surgery, recent surgery, you have to be careful with these lymph nodes. They can become apparent, but there is otherwise little chance of inflammatory nodes in this chain.
Any comments from the audience or from Italy? It's the same. It's the same case. But same case, but let's, in addition to what I first said, there was nothing in the thorax. What if you have a lymph node which is clearly positive?
Perhaps the same procedure for the abdomen. And then I was following what you were saying, that it's not easy to perform biopsy there. To me, it seemed to be quite easy to arrive there and to get the biopsy, but I don't know.
It's a parasternal node, so
no,
it's not so
it's
easy.
Too difficult. Okay, so perhaps radical hysterectomy,
the same surgery.
Same surgery.
Bologna, the same? Somewhere
I
else?
don't know exactly. The problem is that I was wondering, what's the accuracy on estimating the size of that lesion? I mean, what's the size? Would the radiologist tell me exactly which size the node is?
That's a 5 millimeter sized
So
lymph
it's
node.
very small. Less than
But
1
that's a
centimeter.
big misunderstanding. If you look at the literature by Sloan Kettering, they say the size for abdominal nodes is 1 centimeter. But for thoracic nodes, to look at the outcome of the patient, actually the threshold is 5 millimeters. And you have if you withheld the 5 millimeter lymph nodes in patients with debulking, that was a retrospective series out of Sloan Kettering, they had clear influence on the outcome of the patient. If they took the 1 centimeter threshold in the chest, actually there was no influence on outcome. So we have to be more sensitive for the lymph nodes in the chest compared to the ones in the abdomen.
No other comments? Well, my personal opinion is if it's stage 4 and you're sure about it, then we would go for neoadjuvant chemotherapy based on the UTC study. But if this node would have been paracardiac and it's easy accessible, we remove them. Like I said this morning, paracardiac nodes are through the diaphragm, which you have to open anyhow in these cases with diaphragmatic metastasis. Then we remove it, or retrocrural. Then we remove it. But if you can't get complete debulking, then we prefer to start with neoadjuvant chemotherapy. I would not worry about Avastin. In these cases, we always give Avastin. And then after 3 courses, we repeat the MRI, and almost always these nodes are gone. Of course, if you have progression during the first 3 courses, then this debulking doesn't make sense, but that's only 2 to 3%, as I showed this morning. I took this one on purpose because with only 1 node, if you have, of course, a whole chain of mediastinal nodes, I think nobody would have said primary debulking. That's why I showed this picture. But here we differ, and here based on the fact that it's stage 4, and that we know that the survival is the same in stage 4, and on the contrary, in stage 4, it's in the subgroup analysis, it's better. You can operate it intra-abdominally, but still, I think you will not improve the survival.
I think we also need to consider what is the intra-abdominal tumor load. If this same patient with a 5 millimeter lymph node had a disease in the superior, in the celiac trunk or the pancreatic tail or the liver porta hepatis, so operable, but with a very, very extensive surgical effort.
Yeah.
And she would also have ascites, so you would really need a massive surgical effort in order to clear her. With extra-abdominal disease, I would also do it.
Yeah.
In this case, the patient had intra-abdominal spread, but it is in very easy debulked. I mean,
yeah, that's why I've put the case up like
so
that, because if it's extensive disease with a lot of with a very large surgery, there is no doubt, I think.
Exactly.
But
So
here we can discuss, even we would discuss that, but normally in this case, I would say let's start with neoadjuvant. But I agree, of course, if this would have been a much larger operation intra-abdominally, with this finding, it would be easier to choose, but that was on purpose. Okay, then I think I would like to ask Christina to present the second case.
So we go now to an easier tumor, but I think to a more complicated case. We have a 32-year-old patient, newly gravida, so never having born any children, no partner, so not in a relationship, nothing. And she went to her gynecologist because she felt something, she was not sure what it was happening, and she started having some pelvic pain. She was seen by the gynecologist. The gynecologist examined her. She did an ultrasound. She did tumor markers, and what she saw was a normal tumor marker, as somebody would expect, and no ascites, no free fluid, no hydronephrosis. But performed also an imaging, performed so that it's easier for you a sonography and also an MRI. And these pictures are not from me, but are from Ignace, who kindly brought them to me, where we see a large tumor in the pelvis with a perfusion time. It's a perfusion weight MR, a diffusion weight MR, and then we see a borderline, suspicion of a borderline tumor. And it was actually very interesting because it was one big mass with only one solitary, very small papillary structure there, as you can see, but nothing really else. Other ovary normal, upper abdominal organs completely normal, no ascites, nothing. What would you discuss with a patient? I think we can have the lights on again before everybody falls asleep. And I fall asleep. So what would we discuss with a patient? She's 32, she doesn't have children, she has a big mass. What is the big mass, 10 centimeters mass? What is the first question that you would, the first issue that you would discuss with her? Exactly, fertility sparing surgery, that's exactly right. How would you operate her? 10 centimeter mass, suspicion of borderline, not really suspicion of cancer, but yeah, nobody can exclude it. Laparoscopy or laparotomy? Who would do a laparoscopy? No, a bit longer, I can't see. So who would do a laparoscopy? And laparotomy? Okay, so almost half-half. So, first question, laparoscopy versus laparotomy. She's a young woman, she doesn't have a partner, she doesn't want a laparotomy, of course, but on the other hand, we have a tumor with a papillary structure. It could also be in 1A ovarian cancer with a normal tumor marker, so we have to weigh up to balance spillage of tumor cells versus the cosmetic effect. I think it's an issue of who operates, who goes, who approaches this patient. We know that a very skilled laparoscopic surgeon can make it and also can take out the mass with an endobag. Ignace, what would you do?
I think a tumor of 10 centimeters.
Yeah. You have to push.
Continuously.
Yes. Yeah.
I think in a tumor of 10 centimeters with probable borderline, I would be conservative and I would still like to do a laparotomy and stage this patient completely. But I think it's certainly in smaller borderline tumors you can do a laparoscopy. But I think when you saw the ultrasound in the MRI, I would prefer to do a laparotomy.
For a laparotomy. Mm-hmm. Yep. Yes, yes. Oh, no? Yeah? Oh, I can hear you. It's fine.
Can you hear me?
Mm-hmm.
Yeah. This is a typical situation
Yeah,
when
exactly.
we are really very uncertain because we can tell you that we have a suspicion of malignancy, but we cannot be sure between borderline and invasive. So you suggested that you counseled the patient and you tried to perform cystectomy. Am I right?
No, I don't think it is a matter of cystectomy.
No?
I think it's I think so. I wouldn't discuss with the patient a cystectomy. Ignace, would you? I would discuss a salpingo-oophorectomy.
What depends. I think when you open up and based on the imaging, if all points to a stage 1 borderline, certainly a serous tumor, I would consider a cystectomy, but it's quite large. If it would be smaller, I would try to do a cystectomy, certainly in a serous tumor borderline.
Yeah, and in this context, a question to the pathologist. If you, let's imagine less than 7 centimeters, 5 centimeters. So do you ask for frozen section? Of course, I suppose. Do you ask for frozen
It
We-
doesn't,
we do.
I don't think it has any clinical relevance, the frozen section, because we know that the accuracy of frozen section, of course, it depends on the institution. If you ask the Mayo Clinic, who do frozen section in every patient, and they have a very high turnover and very high experience, it's different than a normal other cancer institute. But we know from the large robot data, which are more than 1,000 patients in borderline across in Germany, that the inaccuracy rate of frozen is something like 15-20%. It's very high. So to really take out lymph nodes, take out to do a big surgery and also sterilize a young patient with no children, based on a frozen, I wouldn't do it. And this is, of course, where we go with the next step regarding 1 or 2 stage procedures. So you need to discuss with the patient how far would you go.
We also do frozen sections, and our pathology is very reliable, but it's very, very person dependent. We also have a devoted pathologist who just does gynecologic pathology, and he usually does these frozen sections, and it's very reliable. And concerning your point, in the robot study, you see a lot of under-diagnosis. But
True.
Yes, but the fact that you get on frozen section, let's say, a high-grade serous invasive stage 1, making a lymphadenectomy necessary, and finally a borderline is very improbable. So I think at the borderline you often have an underestimation of the aggressiveness, especially in mucinous tumors, which are quite different from place to place where you take your frozen section. But having because for instance we don't do lymphadenectomy in a grade 1 serous tumor. Yeah? So that's different, of course, from policy from hospital to hospital. But an underestimation on frozen section, of course, you can have because you have only 1 or 2 frozen sections. But an overestimation, changing a high-grade serous to a low-grade serous tumor, I think this is quite improbable.
It is, however, we have to say that in a young patient, if she knew it is a high-grade serous ovarian cancer, she may not have wanted a fertility-sparing surgery. So I think this is why in these patients who are very young, who don't have children, we need, one of the first questions is in terms of 1 or 2 stage procedure. If the woman wants a 1 stage procedure, where she knows all the inaccuracy risk of frozen, she knows the fact that we can from laparoscopy convert to laparotomy, she knows the fact that we may take out both of her ovaries and then be a borderline at the end. Or to just remove the mass and then have the 100% certainty of a final histology 10 days later and then operate her, where the outcome, the survival difference is not really different, just she would have a second procedure. This is something that needs to be discussed with the patient. Yes, you have a question?
Just a comment. I think using MRI, we are, with morphologic and functional criteria, we are totally able to differentiate mucinous borderline cystadenoma, which look like usually a big tumor. So the problem will be the same for most of mucinous borderline tumor from mucinous cystadenocarcinoma, because for the mucinous borderline, we have only signet irregular septa, and mucinous cystadenocarcinoma, we have solid nodules. And in our practice, when we suggest it's possibly only borderline, our surgeon perform frozen section, and the pathologist know the MR imaging, know where to look for the abnormal, possibly malignant tissue. And as he know the images, I think there's less false negative frozen section, and we have, I think, a low rate of second surgery after the first surgery. So it's our practice in Paris.
Yeah. Maybe you can ask the pathologist for a comment on the value of frozen section.
Yes, exactly. The value of frozen section in borderline.
So I think that in ovarian borderline serous, we have the possibility to reach the diagnosis easy in a specialized center, of course. We have some problem about mucinous borderline tumors because the tumor is heterogeneous. It may contain area of benign, borderline, malignant in the same tumor. So we cannot be conclusive in a frozen section. But in my opinion, in serous borderline tumors, we can. We can fail with low-grade serous carcinoma. It's very difficult to mislead a high-grade serous carcinoma between a borderline. So in my institution, I work with Antonia, they give us every specimen for frozen section. I think that is good for the pathologist because it can be the color, the mass, the morphology. It's very useful.
I think it's again a matter of effort to do a laparoscopic pelvic and parotic lymph node dissection in a young patient who, even in 1% of the cases, might not be necessary. I wouldn't do it. I wouldn't do it, and I wouldn't want it on myself. On the other hand, to perform just some peritoneal biopsy, cytology, and a big omental biopsy, where the morbidity of this and also the extent of the surgery is only a few minutes, has a completely different effort compared to perform a pelvic and parotic lymph node dissection. This is why, even in this case, even if the pathology would tell me it's probably nothing, I would do some peritoneal biopsy and an omental biopsy so that I don't need to operate the patient again for a few biopsies. So I would just go with the easier for me, for theater and for the patient, and with the less effort and morbidity for the patient. But again, these are things that we need to discuss. Good. So what happened? We did a laparoscopy, we did a unilateral salping oophorectomy, we did peritoneal biopsy, cytology, and omental biopsy. And the diagnosis was a serous borderline 1A, so we managed without rupturing it in the abdomen, and negative peritoneal staging. By the way, what we saw in many retrospective analyses, we don't have any prospectively randomized trials, but in many retrospective analyses, there is no real meaning or survival disadvantage of iatrogenic borderline rupture or of positive cytology in borderline tumors. And we saw it also in the robot data that whether you do laparoscopy or laparotomy doesn't really have a difference. The problem that only is the risk that is there is that if you miss a serous 1A ovarian cancer, where you have an upgrade 1C disease, so that's an issue. Okay, so follow-up. How would you do your follow-up? So the woman has a uterus and has another ovary.
Transvaginal scan.
She wants to be on the pill. No, she doesn't have a partner, so she doesn't need the pill, and when she gets a partner, she wants children. Suppressed.
Is there evidence that works?
There is no evidence.
No.
So there is evidence that we have we don't have an ovulation, we have less functional cysts, yeah, but we don't have, I wouldn't know that we have a protective effect of borderlines with a pill. No, we don't.
No.
We don't actually.
We would follow her up by means of transvaginal scans.
With?
Transvaginal scan.
Yeah. Would you do CA 125?
No, never.
Okay, exactly. So this woman didn't have any elevated tumor marker, so the probability that she has a small relapse in the other ovary and the tumor marker is elevated is very small. We also did, again, within the robot trial, which is just being accepted in the National Journal of Gynecologic Cancer, that the follow-up and diagnosis with CA 125 in borderline serous has no benefit or no value. So we wouldn't do it, but definitely an ultrasound, especially for the other ovary. How would you do it here in Leuven?
Yes, I think what you said, ultrasound is the essential in conservatively treated ovarian cancers.
Good, good. So further discussion, what other points do you need to discuss with this patient? She has one ovary, she's 32, she doesn't have a partner, and at some point she wants to get pregnant. And she has a disease that is serious and sometimes can come to the other ovary. Yeah, of course. Egg retrieval. Then second question, where, yeah. Mm-hmm.
To consider ovarian preservation.
Exactly. With what? Ovarian preservation with what?
To preserve the ovary, the one that's left. You can preserve it.
With, okay. Hmm? So egg retrieval or?
Cryopreservation? Is that what you call it? Of the oocytes.
Or oocytes, yeah, exactly. So yes, definitely. So that is a question that many people, many women ask. It depends on country to country. In Germany, for example, it is something that the insurance companies don't cover. I don't know how it is in the UK, really. And in Germany, the patient would need to pay for herself. I don't know how it is here.
It's possible, but the results of egg retrieval are not so very good, and the same for cortex retrieval. So about the first point, I think completion of surgery after, if this is a usual type serous tumor, not a micropapillary, we don't do that anymore.
Well, you don't?
Completion after completion surgery after completion of childbearing wish in usual type serous tumors 1A, we would not do that.
You would not do that, okay. Rome, how would you do it? Would you remove the other ovary if she would have had then 3 children and would be 40?
We discuss with the patient because sometimes we wait for the menopausal status. And some women, they want to arrive there with the remaining ovary. Also because we know that we can easily detect a recurrence within the ovary. So not straight, we remove the ovary in the presence of a borderline.
So there are absolutely no data that would show a survival benefit. Dirk, do you want to say anything, no?
I think we have to close here.
We have to close, okay.
Because
we will miss a relapse.
We still need a coffee break, and we have to start again here at 4:20, because at that time then we can finish on time at 6 o'clock.